Hello everybody, my name is Heather Brown. I'm a registered nurse at Gurnick Academy of Medical Arts. This presentation will be on Chapter 10, Nutrition During Pregnancy and Lactation. This information will be on your upcoming nutrition quiz on Monday, April 27th. That quiz will cover Chapter 10, 11, and 12. So this chapter explores the nutrition needs of pregnancy, nutrition-related risk factors and complications, as well as the physiological process and nutrition demands of lactation. Lesson 10.1, Nutrition Before and During Pregnancy. So the mother's food habits and nutritional status before conception and especially during pregnancy influence the outcome of her pregnancy. Pregnancy is a prime example of physiological synergism in which the mother, the placenta, and the fetus collaborate to sustain and nurture new life. Basically, the mother, the placenta, and the fetus are all working together, okay, in unison. Through the food that a pregnant woman eats, she gives her unborn child the nourishment required to begin and support fetal growth and development. We're going to go through everything that she needs during pregnancy in this presentation. Nutritional demands of pregnancy. Mother and child's health depend on the pregnant woman eating a well-balanced diet with adequate essential nutrients. So we've talked about essential nutrients in the past, so now we're connecting that to pregnant moms. Women who have eaten well-balanced diets before pregnancy are in good state of nutrition before conception, so it's important that moms are healthy going into pregnancy. 9 months of pregnancy require increased energy as well as nutrient support. These general guidelines are based on DRIs, and we're going to go over some of the guidelines upcoming in this presentation. And lastly, nutritional needs are based on the mother's age, along with her height and pre-pregnancy weight. So some of those BMI determinants there. So nutritional needs during pregnancy are definitely affected by the mother's age, and we'll talk about this more. But the mother's age is an important factor that affects the nutritional needs. The 9 months between conception and the birth of a fully formed baby is a spectacular period of rapid growth and fetal development. Such activities require increased energy and nutrient support, which we'll be talking about. Energy needs are increased. So here we're referring to pregnancy and how energy needs are increased during this time. So on this slide, we see the reason for increased needs as well as the amount of energy that needs to be increased. So some of the reasons for increased need is to increase the metabolic workload. So mom's very busy creating new life. So this is requires more intake. Also to spare protein for tissue building requirements. So we've talked about protein and how its major function is for tissue growth and repair. So we want to spare some of that protein for tissue building requirements because a lot of tissue is being built. So we want to use spare that protein. And on the bottom, the amount of energy increase. So in the second trimester of pregnancy, moms need about 340 extra calories every day. In the third trimester, moms need more like 450 calories per day increase. So a big part of nursing education here is a lot of times they say you're eating for two. Now, that's a misconception, definitely. So in the second trimester, an extra 340 calories, that's not much extra. That might be an extra fruit cup and a granola bar. That's not a whole lot. Now, a whole person, 2,000 calories or so that they eat, you're not eating for a whole nother person. You're eating just an extra, I would say 1 to 2 small snacks. Third trimester, approximately 452 extra calories. It is important that you are able to identify how much more extra calories a pregnant mother would need. So here's some numbers here for you guys to reference. So of course the exact amount of extra needs are going to vary depending on the woman, also depending on her pre-pregnancy weight, her health status, and how active she is. So these are approximate numbers, but of course the actual amount can vary depending on the mom. But I do want to highlight the samples that they're giving here. Second trimester, 340 calories per day. Third trimester, 450 calories per day. And the need for you guys as nurses to educate moms that it's not actually a whole second person. We're talking 1 to 2 extra small snacks a day. Protein needs are increased. So we know that protein plays a huge role in tissue growth and repair. So here protein's needs are increased because we're developing the placenta. There's also rapid growth of the fetus, growth of maternal tissues, as well as increased maternal blood flow. So mom's blood flow, she has a lot more plasma volume. We have an increase 40 to 50% during pregnancy because mom's blood has to nourish baby. So we have an increased maternal blood volume during this time where the mother's plasma volume increases 40 to 50%. So we have more circulating blood is necessary to nourish that fetus and support the increased metabolic workload. So mom has lots of work to do, more blood for baby, more blood for mom. And amniotic fluid. This contains various proteins. The purpose of amniotic fluid is to help protect the fetus from shock or injury. So it's kind of like a waterbed for baby. It helps prevent shock or injury, so it acts as a source of protection. Protein increase. So the amount of protein increase for pregnancy should be about 25 grams per day. So they calculate this by knowing that the average person eats 46 grams of protein a day, and a pregnant woman should have approximately 70 grams of protein per day. So those two numbers, we have an approximate 25 grams per day increase of protein. So food sources include complete protein foods, as well as incomplete protein foods. So we've discussed complete proteins and incomplete proteins before, but incomplete proteins are missing or do not have enough of the essential amino acids. So these are usually more of the plant-based type of things, while complete are generally animal-based and have all of our essential amino acids. So here we see some complete protein foods and incomplete protein foods. Complete includes milk, eggs, cheese, soy products, and meat, whereas incomplete includes legumes or grains. Protein-rich foods also contribute calcium, iron, zinc, and fat-soluble vitamins. Key mineral and vitamin needs. So all nutrients are of great importance in the mother's diet. Teratogenic effects may develop as a result of a maternal diet that is deficient in many of the minerals, and we'll talk about that later. Calcium. So we're going to focus on calcium quite a bit in this slide. So calcium is necessary for lots of different things. Calcium is essential for fetal development of bones and teeth, as well as for the mother's own body needs. Milk and milk products are a great source of calcium during pregnancy. I'll repeat that. Milk and milk products are a great source of calcium during pregnancy. Also, generous amounts of green leafy vegetables and enriched whole grains are also good sources of calcium, but milk is our number one good source of calcium. So a good supply of calcium along with phosphorus, magnesium, and vitamin D is essential for the fetal development of bones and teeth, as well as for the mother's own body needs. So calcium here, we gave the big example of milk. Other good sources include generous amounts of green leafy vegetables, enriched whole grains are also good sources. Key mineral and vitamin needs. So here we're going to be focusing on iron. Iron is essential for increased hemoglobin synthesis. So we need iron to make more hemoglobin. So why is more hemoglobin desired during pregnancy? So remember we said there's an increased maternal blood volume. Mom has more blood volume. Also for the infant's storage of iron. So deficiency affects approximately 30% of low-income pregnant women, and they may need supplements. So let's talk about supplements of iron for a second. So doctors usually recommend taking iron with orange juice. So vitamin C, which is heavy in orange juice, increases the body's ability to absorb and use iron. So many times if a woman needs iron supplements, doctor will recommend that she takes it with vitamin C. Also, if she's going to be taking an iron supplement, women can avoid unpleasant GI effects if they take it between meals or at bedtime to help prevent these side effects, some of these GI things that can happen, nausea, vomiting, perhaps even diarrhea. So foods that are a good source of iron include beef, Green leafy vegetable are good sources of iron. But here we also covered if supplements are needed, how a woman might want to take those supplements. Key mineral and vitamin needs. So the DRIs for pregnant women are slightly higher for most vitamins. As total energy intake increases, so do the nutrients contained in the foods consumed. So to break this down, mom needs more vitamins, but she's also eating more food. So as she eats more food, the vitamins that she intakes should be higher. So we can kind of balance that need here for extra by eating more food. So if she's choosing good foods, she's going to have the nutrients and vitamins that she needs increased as well. Therefore, the recommended intake for most nutrients is achieved through a selection of nutrient-dense foods. So as long as mom's taking in those extra calories on good healthy foods, nutrient-dense foods, she should have what she needs in those increased caloric intake. Key mineral and vitamin needs, here we're focusing on folate. So you might see folic acid on a bottle of vitamins instead of folate because folate is a salt of folic acid. So we might see folic acid instead of folate. So this builds mature red blood cells during pregnancy. It's especially important during early periconceptional period. Periconceptional means around the time of conception. So approximately 2 months before conception to week 6 of gestation. So this is very, very, very early in pregnancy. It's the periconceptional period where mom needs a lot of folate. Decreases incidence of neural tube defects such as spina bifida and encephalopathy. So spina bifida, the thing about spina bifida is that a lot of times in this very, very early time period, mom might not even know she's pregnant. So this happens so early, and if she doesn't have enough folate, it can potentially lead to neural tube defects. The specific neural tube defect that we see most commonly is spina bifida. So adequate folate in the periconceptional period will help prevent neural tube defects. So I'll repeat that. Adequate folate in the periconceptional period helps prevent neural tube defects. The ones we're specifically focusing on is helping prevent spina bifida. So some foods that are a good source of folate include enriched flour and grain, green leafy vegetables, soybeans, orange juice, asparagus, broccoli. These are all good sources of folate. Folate helps build those mature red blood cells throughout pregnancy and is particularly needed during the early periconceptional period to ensure healthy embryonic tissue and once again help prevent those neural tube defects. So our DRIs, daily folate intake of 600 micrograms during pregnancy and 400 micrograms per day for non-pregnant women during childbearing years. So they may require folate supplements. So what we see on this DRI is non-pregnant women should also consider the use of folate supplements because, like I said, it happens so early in pregnancy. A lot of times before mom even knows she's pregnant, she can already be potentially putting her fetus at risk for spina bifida. So they do recommend that all women in their childbearing years takes this folate. So in case she became pregnant, she would have less risk factor for a neural tube defect. Key mineral and vitamin needs continued. Now we're focusing on vitamin D. So deficiency in vitamin D is a worldwide problem. Vitamin D ensures absorption and utilization of calcium and phosphorus for fetal bone growth. So vitamin D is very important. Daily intake of at least 3 cups of fortified milk. So fortified milk contains extra vitamin D. So we need vitamin D. Pregnant mom needs this. So milk fortified will contain extra. So that's a good thing. Exposure to sunlight increases endogenous synthesis of vitamin D. So that means if mom goes out in the sun, it helps with the vitamin D that she helps create, okay, herself. So extra sunlight will help that synthesis of the vitamin D that she takes in. So extra fortified milk, a little extra sunshine, all good for mom, good for that extra vitamin D. Weight gain during pregnancy. So we want to set weight goals according to mother's pregnancy nutritional status as well as her BMI. So remember height and body weight. So here are some numbers. An underweight woman should gain the most, so 28 to 40 pounds. So weight gain used to be one size fits all, meaning years ago that you'd tell every pregnant woman you should gain 25 to 35 pounds. So every woman 25 to 35 pounds, but it's not one size fits all. Definitely depending on mom, how much her height and weight is, as well as her pre-pregnancy nutritional status, her current nutritional status helps dictate how much weight she should gain. So underweight women, we see here 28 to 40 pounds. Normal weight women are 25 to 35, so that used to be kind of that cookie cutter weight gain that they'd give you. Overweight women should gain 15 to 25 pounds. And lastly, obese women should gain 11 to 20 pounds. And then for twins or triplets, obviously a big window here, depending on if we're dealing with twins or triplets, is 37 to 54 pounds. So we've went from that cookie cutter, one size fits all weight gain to a very different weight guidelines for each group of women, as well as their nutritional status is taken into account. Rate of weight gain. The average amount of weight gain during the first trimester is 2 to 4 pounds. So this is an average. Of course, going to vary depending on mom and how much she weighed, but this is an average is 2 to 4 pounds. So I'll repeat that. The total weight gain during the first trimester should be an average of approximately 2 to 4 pounds. So 1 pound per week weight gain during the remainder of the pregnancy. So 2 to 4 pounds in that first trimester, and after that, approximately 1 pound per week. Once again, depends on the size of mom. Increased energy demand in late pregnancy. So we saw that earlier in the second trimester and the third trimester that we needed more calories there towards the end. An insufficient or low maternal weight gain is a predictor of small for gestational age infants, so SGA infants, with increased risk for complications. So if mom's not gaining enough weight, then she could have a small baby, and then that carries its own risks and complications. So do make sure that you know how much mom should be gaining during that first trimester, as well as we previously focused on those caloric intake needs there in the second and third trimester. Daily food plan. So the core food plan is designed to meet increased nutrition needs, which we've talked about those increased nutrition needs. It should be varied and well-rounded, including all food groups, designed to supply the essential nutrients. So something that we talked about as well as some of those key nutrients that are needed. Ethnic background, belief system, and lifestyle may require alternative food plans. So if somebody is a vegetarian, of course their food plan is going to be different than somebody else. So lifestyle and treating each patient like an individual is definitely necessary to make sure that mom's getting what she needs. And then here on the bottom, this is a little hard to view. Pregnant women should, 1, eat a sufficient quantity of high quality food, and 2, eat regular meals and snacks and avoid fasting and skipping meals. So mom needs to make sure that she's getting steady meals, regular meals, snacks, and she doesn't want to skip or fast. Functional gastrointestinal or GI problems. So on this slide, we see constipation as well as hemorrhoids. So let's focus on constipation first. So constipation may occur in latter part of pregnancy. It can occur in any point, but it definitely can occur in the latter part of pregnancy as well. It can be from the result of increased pressure of enlarging uterus and reduced normal peristalsis. So peristalsis is something that we talk about early on in nutrition. So think of that growing fetus, and the uterus is getting larger and it's putting pressure there on our intestines. And as we do that, that normal movement, that peristalsis, starts reducing. So that's why they say constipation can occur in the later part of pregnancy, is because as it gets bigger, as the uterus enlarges and the fetus is growing, we have more pressure therefore perhaps more constipation. Some remedies include exercise, so the more we move, the more it helps aid that peristalsis. Also increase fluid intake, as well as high fiber foods. So we've talked about how fiber adds bulk to the feces. So if we increase our fiber foods and we have more bulk in our feces, so our feces is larger, then it can help that peristalsis, that added water, and that exercise all working hand in hand, and we can help fix that constipation. So those are some remedies. And then on the right, we have hemorrhoids. So these are caused by increased weight of baby, so more pressure. Hemorrhoids can usually be controlled by dietary suggestions used for constipation. So that's why we're seeing these two concepts going hand in hand. So if we can help the constipation, a lot of times we have less incidence of hemorrhoids. So these two things are going hand in hand. Functional gastrointestinal or GI problems continued. So here we see heartburn. So heartburn caused by pressure of the enlarging uterus. Once again, uterus is getting larger, it's pushing upwards, and it can create that heartburn. Dividing daily food intake into a series of small meals usually relieves the condition. So what we want here is larger meals, so fuller stomach, fuller intestines, more pressure, more upward pressure, more heartburn. So they do encourage smaller meals to help relieve that excess heartburn. Hyperemesis gravidarum. So this is a condition of severe and prolonged vomiting during pregnancy. So let me repeat that. Hyperemesis gravidarum. This is a condition of severe and prolonged vomiting during pregnancy. So we're not talking just a little morning sickness, nausea, vomiting here or there once or twice. This is somebody who's going through nausea, vomiting, usually throughout most of their pregnancy, and a large amount of vomiting. Gastric reflux may occur in the lower esophagus, causing irritation and a burning sensation. High-risk mothers and infants. Identifying risk factors and addressing them early are critical. So we always want to make sure we're keeping an eye on risk factors for mom and make sure to address them early. Identifying poor food patterns can also prevent nutrition problems. Some of these poor food patterns could be insufficient food intake, perhaps poor food selection, or poor food distribution throughout the day. So remember how I said we want to make sure that mom doesn't fast or skip meals. So poor food distribution, how she's eating her food throughout the day, can also be a poor food pattern. High-risk mothers and infants. So here we're focusing on teenage pregnancy. So there's a special nutritional care must be given to support the adequate physiological growth of both the mother and the fetus because mom's still growing. So in this case, teenagers are at high risk because they themselves are still in their growth process. The current DRIs distinguish specific vitamin and mineral needs for pregnant females who are younger than 18 years old. So pregnant teens have a higher rate of low birth weight infants, as well as a higher rate of infant mortality. So some special considerations for pregnant teens. Remember I said they themselves are still growing. A lot of times, another consideration is they might not have access to a steady income. So financial concerns. This is also a time of their lives where maybe they're experimenting with smoking or drugs. So lots of special considerations for this population. So a pregnant adolescent is especially at risk because she herself is still in the growth stage of development. High-risk mothers and infants. So recognizing special counseling needs. So we're going to start with age. So we talked about adolescents, our younger moms. Women greater than 35 years old also have special needs. So some special considerations here are this is an age where there might be more hypertension or high blood pressure. Also potentially higher sodium intake that coupled with hypertension puts mom at risk as well as baby. Next, parity, several pregnancies within a limited number of years. So moms who have had several babies over a limited number of years, they need special counseling, perhaps special needs. Obesity. So obesity is a big one. So a very overweight pregnant woman, somebody who's obese, she runs a risk of having possibly gestational diabetes. Alcohol is a potent and well-known teratogen. So we do cover that later on in this lecture. So it can lead to fetal alcohol spectrum disorders, or FASDs. Nicotine, smoking causing placental abnormalities and fetal damage, and drugs, either medicinal or recreational. All of these are different factors that would require special counseling needs. So a very overweight pregnant woman, especially on the older side, she's at high risk for gestational diabetes. So risk factors for women who are more than 120% of standard weight or who have a BMI of more than 26 definitely includes gestational diabetes. During pregnancy, there is an increased metabolic workload along with an increased volume of blood and its load of metabolites, which increases glucose. So all of this extra need, all this extra workload increases the blood sugar. So for women who already have a high BMI, who are older, run at a higher risk for gestational diabetes. So here we're seeing some characteristics of fetal alcohol syndrome, or FAS. We see small head circumference, perhaps a flattened nasal bridge. We can see low set ears, maybe a thin upper lip, or a small jaw. Several different things that we can see here. So during pregnancy, women should be encouraged not to drink alcoholic beverages. So we want to make sure that we're educating our moms not to drink alcoholic beverages. Excessive use of alcohol can lead to this fetal alcohol syndrome. Alcohol, nicotine, recreational drug use can cause fetal damage, and they are definitely all contraindicated in pregnancy. High-risk mothers and infants continued. So here we have caffeine. Caffeine crosses the placenta and enters the fetal circulation. Studies have found conflicting effects on pregnancy. So caffeine here crosses the placenta and enters the fetal circulation. The next thing we have here is pica. So this is where mom actually craves and potentially consumes non-food items. So top left of our slide, we see a mom chewing on a soap bar. So the common pica foods for a woman to crave these non-food items, but that she just gets a feeling like she needs to eat it, is usually chalk, dirt, or soap. So this is a real thing. Usually when I lecture you guys in person, I like to see the shocked faces like, oh, are you being serious? So pica, this is where mom wants to consume. She has a craving for non-food items. Common ones, we see the soap in the picture. Other common ones are chalk or dirt. And then on the bottom, we have socioeconomic difficulties. So poverty reduces access to resources. So we know this. If mom doesn't have money, she doesn't have enough money, she has less access to resources. Community resources include WIC. So WIC is Women, Infants, and Children Program. So it's the Women, Infants, and Children Program. This provides food stamps and other services to pregnant women. So that's one community resource. If you know that a mom that you're working with is having a socioeconomic difficulty, definitely make sure that you're providing her some resources that can assist her. Complications of pregnancy, and we're going to start with anemia. So anemia, this is deficiency of iron in mother's diet. Dietary intake must be improved and supplements used as necessary to avoid the long-term detrimental effects on the fetus. It serves as a risk factor for low birth weight baby. So the most common cause of anemia during pregnancy is iron deficiency. I'll repeat that. The most common cause of anemia during pregnancy is iron deficiency. So we want to go back to your iron slide, look at some of the key points there, because iron plays a huge role here in anemia. Next complication is intrauterine growth restriction, or IUGR. This is caused by low pregnancy weight, inadequate weight gain, and potentially smoking. Complications of pregnancy continued. We're going to start with hypertensive disorders of pregnancy. So the etiology or the cause is unknown, but it's classified into categories. So this high blood pressure during pregnancy, the categories include chronic, gestational, preeclampsia, eclampsia, and eclampsia with chronic hypertension. So let's break down a little bit of this. So high blood pressure and the accumulation of protein in the urine are signs of preeclampsia. So preeclampsia and eclampsia are associated with poor fetal outcomes, such as maternal and fetal morbidity and mortality, as well as potentially small babies, low birth weight, or preterm delivery. So what we're talking about here is high blood pressure that ends up affecting mom and baby. So high blood pressure and the accumulation of protein in the urine may be signs of preeclampsia. If not treated, preeclampsia can progress into eclampsia, and it can go all the way to potentially seizures or even death. And then on the bottom, gestational diabetes. Gestational diabetes, so glucose intolerance with onset during pregnancy. So we talked about how the body's working more. This requires more sugar. So the more sugar you have, the more sugar that can be in the bloodstream, therefore higher blood sugars. So the big key here is, remember how I said moms who are heavy and older are more predisposed. So definitely weight and age play a huge factor here. Treatment can be with diet and exercise is the first line. So what we don't want to do is start putting moms on insulin unless they need to, and then definitely we will. But hopefully, if it's a more mild case, we can treat this gestational diabetes with diet and exercise. If not, then we would go to oral medications or even insulin if needed. Glucose tolerance, we have a one-step or a two-step process. So these are basically lab work where mom drinks a very sugary drink, and then they see how her body responds to processing that amount of sugar. If she can adequately process it, then she's not diagnosed with gestational diabetes. If mom drinks the sugary drink and she is not processing that sugar well and it's staying in her bloodstream, then she could be diagnosed with gestational diabetes. Predisposing factors. So predisposing factors to gestational diabetes include previous history of gestational diabetes, if mom's had it before. Also family history of diabetes. There's also ethnicity that's associated with high incidence of diabetes. These include Asian, Hispanic, African Americans, and Native Americans. Also, if mom's overweight or obese. So these are all some of the predisposing factors. Possible consequences, baby could be stillborn or macrosomia. So these are just some of the consequences of gestational diabetes. Complications of pregnancy. So pre-existing diseases such as cardiovascular disease, hypertension, if mom had type 1 or type 2 diabetes coming into pregnancy, HIV, if she has an eating disorder like anorexia or bulimia, inborn errors of metabolism or allergies or intolerances. All of these pre-existing things that mom had before being pregnant, can lead to complications of pregnancy. So here's just a basic list of pre-existing conditions that could affect mom while she's pregnant. Lactation. So it's recommended as an exclusive source of nutrition for infants up to 6 months. So they recommend only breast milk for the first 6 months of baby's life. Of course, each parent is going to choose what works best for them, but that's the recommendation, that only breast milk is utilized for baby for the first 6 months. Trends. The U.S. rate has been rising since the 1970s. Healthy People 2020 goals include breastfeeding, so there's a lot of focus and education on breastfeeding now. So it is definitely a good thing that our rates have been on the rise. I know that if you have a baby nowadays, they definitely are pro breastfeeding. Once again, it is definitely mom's choice, but there is more emphasis on it than there used to be. Baby-friendly hospital initiative launched by the World Health Organization and United Nations Children Funds outlines 10 steps for successful breastfeeding. So lots of encouragement and lots of education on breast milk. So here we have the anatomy of the breast. The female breasts are highly specialized secretory organs, so they secrete. Throughout pregnancy, the mammary glands are preparing for lactation. So during pregnancy, these mammary glands are getting ready for lactation, so baby can have breast milk. Remember, breast milk is what they encourage for the first 6 months, exclusively breastfeeding for the first 6 months. So here we just see the breast anatomy. So here we see breast physiology. So this is a concept that you're going to discuss more in anatomy and physiology, but best to just learn it here. So we have the mammary glands and hormones. So mammary glands extract nutrients from maternal blood. So we focused on mom's blood. So mammary glands are going to get nutrients from that blood. And they're also going to synthesize or make other compounds. So we have two hormones here. We have prolactin and oxytocin. So prolactin stimulates milk production. So I always think prolactin produces. So prolactin stimulates milk production. So I'm putting the P and the P together. Prolactin produces. So that's our producing hormone. And then oxytocin is what stimulates the letdown. So prolactin produces the milk, but the oxytocin is actually what helps the milk come out. So in this picture, you see mom looking at baby. So as she's looking at baby, we have the hormone prolactin, and it's producing that milk. The oxytocin is actually the one that's having the milk come out. And the sucking effects receptors in the nipples as baby is suckling helps trigger this oxytocin or milk ejection. So we see two hormones here. We see prolactin and oxytocin and how they're both needed for breastfeeding. Physiologic process of lactation. So supply and demand. Supply and demand is what dictates this whole process. So the infant feeding, what we saw in the last picture, that suckling, stimulates the mammary glands to produce more milk. So we have more prolactin. More milk is taken, more milk is produced. So supply and demand. As baby wants to drink more, mom makes more. If baby drinks less, she makes less. So this whole process is governed by this issue of supply and demand. But let's look at the composition. So what's breast milk made of? So colostrum is that first rich in antibodies, a very small amount of colostrum. When baby is just born, baby's stomach is very, very small. So we don't have milk yet. We have colostrum. This is that first tiny bits, but it's very rich in antibodies. Then we have mature milk within the first few days of delivery. So we're going to start with that colostrum, and then the milk is going to mature after the first couple of days. Composition changes during feeding. So it's very different from cow's milk. So definitely during the course of mom breastfeeding, that composition is going to change. So cow's milk is inappropriate for infants younger than 1 year. So it has a high protein and electrolyte level. So we want to make sure that baby doesn't take in cow's milk until they're at least a year old. And do keep in mind that the amount of breast milk moms make, this is governed by supply and demand. So milk production is stimulated by the infant feeding, therefore more demand will equal more supply. Nutrition and lifestyle needs for a breastfeeding mother. So milk production requires an extra 330 to 400 calories per day. So mom needs to take in more calories, roughly 330 to 400 calories per day. Of course, it depends on mom and how much she's producing. There's a need for protein during lactation is 25 grams per day more than the women's average. So just about what she needed when she was pregnant. She still needs to take in that amount of protein. Also kind of interesting, her calorie stays pretty much the same as what she needed when she was pregnant. Also, she needs about 3 liters of water per day. This can be a mix of fluids like water, juices, milk, and even soup can be considered a liquid. Rest as well as moderate exercise and relaxation are necessary, and almost all of the complications encountered during breastfeeding could either be prevented or be treated by motivated and educated healthcare practitioners and mothers. So lactation specialists can help. So like I said, there's a lot of emphasis now on encouraging breastfeeding, education for breastfeeding moms, and lactation specialists. This is their field, so they are definitely key to helping moms. Long-term results of feeding methods. So on the left, we have risks of formula feeding, and on the right, we have advantages of breastfeeding. So on the left, risks of formula feeding. Breastfeeding is the normal method. I kind of like to change normal to more natural method, right? Because each person gets to select what they think is right for them. So breastfeeding is the more natural method. Other methods carry risk for infants. The advantages of breastfeeding include fewer infections, improved cognitive development. We can see an increased rate of sudden infant death syndrome, perhaps diabetes even, heart disease, obesity, and childhood leukemia. Antibodies improve the immune system, and there's advantages for the mother. So it helps decrease her bleeding after having baby. There's also an earlier return to pre-pregnancy weight, and she can also have some decreased risk of breast and ovarian cancer and osteoporosis. So here we see some advantages of breastfeeding and also some risks of formula feeding. And here, guys, we're going to wrap up with these additional resources. So you can refer to either of these. Just if you'd like to, the World Health Organization has many resources. The website is listed there at the bottom. So just in case you wanted more information.